Okay, ladies and gentlemen, thank you for coming to our third webinar. We're obviously covering a lot of COVID material, but one of the key aspects of managing our battle, whatever you want to call it, with COVID-19 is to make sure that we have goals of care discussions with our patients and what that landscape will look like. So to do that, resource optimization and solving healthcare people, we brought back Gianni, which pains me in many ways because of how big his head is. But he does seem to have some knowledge based on some of his publications and experience. So we were somewhat happy to bring him back on and share his knowledge. And so without further ado, Dr. Gianni DiGidio.
Well, perfect. Thanks for having me back. I've given this presentation to multiple residents and other attendings, and I've modified it slightly for the sake of time today and hopefully leave enough time for questions. What I really want to go through and focus in on are sort of maybe right at the start of some take-home messages. I think if you follow this, and I've provided references and we'll mention references throughout, if you follow this framework, I think you'll be absolutely fine. And the other take-home message is to remember that there is a hierarchy of substitute decision-making, and as well that substitute decision-makers need to act on previously expressed wishes, and if there are no wishes, they need to act, or I should use the term consent, based on values, beliefs, and best interests, and we'll get into that a little bit later on. And substitute decision makers, I think one of the fears that physicians have when dealing with substitute decision makers or patients is they cannot demand therapy. What we need to get more comfortable as physicians is proposing a treatment plan, and we'll focus in on that today. So let me technology here, where we go. Okay. So we will develop an approach to end-of-life care discussions based on two things: law, so the Healthcare Consent Act, and the CPSO end-of-life care policy, which has been recently modified and will undergo further or complete revision, I guess, in September 2020. One of the things we as physicians do very poorly and need to do better is understand the approach, diagnosis, and obligations of deeming someone incapable. As well, some of the errors that we make are understanding the hierarchy of substitute decision makers. So many times we as physicians will seek consent from the wrong substitute decision maker. And we also are very poor at understanding the role of substitute decision makers. And I think, in fact, substitute decision makers, as much as they are there to advocate for their loved ones, they are unaware of what they or how they are supposed to behave from a legal perspective. And we'll get into that at Section 21 of the Healthcare Consent Act. And then one of the things I would encourage people to, or physicians to do more often, is actually go to the Consent and Capacity Board. So there is a process of resolving end-of-life care disputes. It is an onerous process and not the funnest process in the world, but I think after you've done it a couple of times, it becomes much easier. And we'll talk about that again a little bit later on. So just to get into policy and law, I think one of the things that physicians are confused about is the whole issue of withdrawing life-sustaining treatment, CPR, and all of these things. So I'll focus in on this at first. I'm not here to go into case law. I'm not a lawyer, but I just want to remind people, physicians, we must obtain consent to withdraw life-sustaining treatment. We cannot make a unilateral decision to withdraw life-sustaining treatment. So if I'm walking through the ICU, I cannot go around and pull everyone's endotracheal tube against their will without consent. You need consent. And that is law. That's the Supreme Court Rizzulli case that I think most people are familiar with, and you'll see that I reference it at the bottom of the slide there. And when a patient or substitute decision maker does not provide consent to withdraw life-sustaining treatment, we need to seek the conflict resolution process, which is an application of the Consent and Capacity Board. I assume most of the people listening today are Ontario physicians. We are lucky enough to have the Consent and Capacity Board, and there are flaws with it, but we'll again get into that a little bit later on. And if you're not getting consent from the, like I said, patient or substitute decision maker, then you need to apply to the CCB. This, however, is different than CPR, and this has recently been changed. The old CPSO end-of-life care policy basically, in summary, said you need to do CPR on everyone unless you get consent not to. That's, I guess, a broad generalization. This was all based on a case. Again, I've referenced it there in the second paragraph, and I won't go into the details of that. But bottom line, and read Dr. James Downer's paper on this that was recently in the CMAJ, is that basically in summary, it's up to the physician about what to provide in a cardiac or respiratory arrest. And we must provide all resuscitative efforts required by the standard of care. So again, this is not entirely clear, but the way most of us will interpret this is that if it falls outside of the standard of care, we are not required to provide CPR or intubate or bring someone to the ICU. And as you see there, they actually put in the recent policy, which may include CPR. So if there are any questions about this, I'm not here to focus in on this today. We can talk about it a little bit later on at the end of the presentation. So what we're going to go through today are some difficult cases that I've been involved with, how to determine capacity, the substitute decision maker hierarchy and role, how to propose a treatment plan, the role of the consent and capacity board, and how to navigate the consent and capacity board process. And while doing that, who to seek help from. If you've never gone through a CCB case, you should at least watch one or be present at one. Nowadays, a little bit more difficult given it's all done via video conferencing. But in the past, these are public hearings. So you can show up and be in a room and listen to the entire process. So these are all cases that I've been involved either directly or indirectly. 35-year-old woman, bilateral almost full hemispheric strokes, below knee amputation, non-compliant diabetic, grade 4 sacral ulcer, in hospital 4 months. Patient did not want aggressive care, but family wants everything. Second case, 92-year-old with upper GI bleed, had 5 bacteremias while in hospital. At the start of his admission in December, was weighing 62 kilograms. By the time I inherited his care in April or late April, he was weighing 39 kilograms, and that's in spite of both TPN and enteral feeding. Demented in the ICU 3 times during his hospital stay. Family insisted on category 1, in hospital 5-6 months. Third case, 70-year-old female, bilateral almost full hemispheric stroke, dialysis dependent, in hospital 4 to 5 months. According to the family, the patient would never accept this outcome, but family wants everything. And 86-year-old with advanced dementia, aspiration events, acute on chronic kidney disease, while in hospital, requires dialysis, and family is adamant based on his wishes he would want to live as long as possible, regardless of any suffering or indignity. I think I got these dates wrong, actually, but anyway, he was admitted in January of 2017 or 16 and died February of 2017 or 18. Can't remember the exact dates. These are non-CCB cases. So 34-year-old female, actually, Kwadwo, you were involved in this. Severe anoxic brain injury from cardiac arrest. Refractory non-convulsive status. Substitute decision maker believes it was from mold in the hotel room and not due to intravenous drug use, which was the likely cause. Believes diet is responsible for poor health. And while in the ICU, despite having, as mentioned, refractory non-convulsive status, thinks propofol is causing her seizures. And another non-CCB case, a 50-year-old female with advanced ALS, can still communicate via eye blinking and eye tracking, does not want life-prolonging therapy. Partner is in the room constantly and wants everything done. Partner has been in the room for 3 days and has not left. So how are we going to deal with that? And last CCB case that I was involved in approximately a year ago, 62-year-old female with Down syndrome and advanced dementia, admitted in September of 2018. Actually, I have to update this slide. Was discharged in November of 2019 of Orthodox Jewish faith. Family wants everything based on religious beliefs. So obviously very difficult cases, and I'll show everyone how to, I guess, tackle these. And this is the tool that I use and reference more times than not. This is from Healthcare Quarterly in 2011. So as you can see there, it's a pretty straightforward checklist that will allow you to meet all the ethical and legal obligations to critically ill patients at end of life. And not only critically ill patients, but I apply this even on the internal medicine board quite frequently. The authors, as you'll see at the bottom, are, if you research them, are all either involved in ethics, law, are well experienced, and I think are crucial folks in terms of providing knowledge on this. And I'll maybe give a quick shout out to Mark Handelman, who's a mentor to me, a colleague, and now a friend who's basically taught me all about this. And we'll go along here. This will probably be hard for you guys to see at home, but bottom line is, I'll summarize what it goes through, is first and foremost, you need to talk to your patient. I cannot tell you how many times I have come on a race call or a consult in Emerge, and the current team that's looking after the patient will basically say, you know, it's a 95-year-old female with advanced dementia, metastatic breast cancer, family wants everything. And I said, well, that's great. Have you spoken to the patient? And more times than not, I'll actually get an answer and the response is no. And there's multiple reasons for this. Obviously, there's times when the patient can't participate in decision making, and we'll get into that during this checklist. But more times than not, there's a communication barrier, whether it be language or disability or whatever it may be. If there is a language barrier, there is no excuse for not being able to find a translator at any time during the day or night. This is available, especially now with COVID. Everything is done via FaceTime or video. You can get someone on the phone. What I would always recommend to individuals is that you have an independent professional translator available to you. If you don't, having someone else who's not involved in the case to translate ideally is the next step. As a last resort, not being untrustworthy, but you should, generally speaking, not have family translate in those situations. So get a professional translator. Getting back to step one, find out what your patients, if they truly understand their condition. More times than not, when I'm on, again, internal medicine or ICU, patients who are in the emergency department, or even in fact been admitted for quite some time, unfortunately, a lot of them don't have a true understanding of their disease. And what I'll do in that situation, what everyone should be doing, is explaining the situation to them and the expected sort of outcomes of that situation, and see if they can retain that information. I'm not here to go through an entire capacity assessment. We'll focus in on that a little bit later on, but find out. And actually, one of the good references, which unfortunately, actually, I found out today, is no longer available through the CPSO, is determining capacity of consent, which is actually a guide that you could find on the CPSO website, which I can no longer find. But what they get into is basically this. So trying to find out if your patient actually understands and is capable in participating in treatment decisions. So do they understand the condition for which the specific treatment is being proposed? So to find out if someone is capable or incapable, for that matter, you have to show as a physician that they either do not understand, do not appreciate, or cannot communicate a treatment decision to you. So find out if they actually understand the condition for which the specific treatment is being proposed. And this can be very simple. And remember, each treatment in the eyes of the Healthcare Consent Act should be dealt with separately. You technically cannot be globally incapacitated. You actually theoretically need consent for every little sort of treatment, but in real life, we don't technically do that. What we're focusing in on mostly here is end-of-life care or advanced care directives. And is that person, moving on to 2, is that person able to explain the nature of the treatment and understand its relevant information? And if they don't understand it, if we have the luxury of time, I will explain it to them as best as possible. I may even get another individual from my team to explain it, and then return back in 5, 10, couple of hours, even next morning, and see if they're able to retain that information. Are they aware of the possible outcomes of treatment and alternatives or lack of treatment? So is someone able to clearly explain to me what's going to happen to them with treatment, without treatment, or with alternative forms of treatment? And can they explain the risks and benefits to me after, obviously, it's been explained to them? And this is something that's very important. Point number 4, are the person's expectations realistic? I cannot tell you how many times I've shown up to a case and a substitute decision maker or patient will be at advanced age, let's say in their they're 85 and they have a whole host of comorbidities. And they will say, well, I want to live to 95 or I want to live to 100. Well, given the current circumstances and their comorbid state, that is not realistic. Some other times they'll say, I want to be able to attend the wedding of my daughter in the summer. And it may be January or February and they have horrendous metastatic disease. Again, that may not be realistic. And is the person able to actually make a decision and communicate a choice? This is very important as well, because there are times where I've dealt with this where a patient will say, I need more time to think, or I can't make a decision right now, or I feel too pressured to make a decision. So that is important as well. And can they manipulate the information rationally? And, oh, I thought I had some more, but I don't. So it is up to the treating physician or the healthcare professional. I'm just going to go back to my checklist to determine whether or not the patient is capable. Let's assume for the most part that our patient is incapable. Let's use the situation where they have advanced dementia or they're in the ICU and they're intubated, sedated, and they can't participate in decision making. That's pretty straightforward. At that point, what's very important is to document that in the chart. So sorry for the flipping through charts here, excuse me, the slides, but you have to document the date, the finding of incapacity, and the reason for decision. If it's related to a mental health issue or a cognitive disorder, they actually have the right to challenge you, and you must provide them with a Form 33 and a Form 3. This gets a little bit more technical, but they do have the right to challenge that finding and seek rights advice. So now that we've deemed someone incapable, it can be very simple. You write in the chart, it's January 14th. I find that Mr. Johnson, due to his traumatic brain injury, is intubated. He cannot participate in decision-making, and it is 8:30 in the evening, and I've documented that he can't participate in decision-making. Just remember that capacity can fluctuate as well. So one day an individual may be incapable due to a urinary tract infection or an overdose or whatever. And when they come out of that delirium a day or two later or a few days later, they may be able to participate in decision making. So it can fluctuate. The next thing is step number 2 is to identify the legally correct substitute decision maker. This is incredibly important. This is law. Let's skip ahead here. This is in the Healthcare Consent Act. For those of you who have never read the Healthcare Consent Act, I suggest you do. Obviously, it's in legal terminology, but it's very important for any practicing physician in Ontario to be aware of it. So I'm not going to go through everything here except to highlight a few important points. Technically, spouse or partner is not until number 4. And a lot of people forget this, that there are other things that supersede a spouse or partner. The important thing for number 5, a child, there's actually no legal age for consent in Ontario. However, if you're a child and you're going to consent on behalf of your parents, for whatever reason, you have to be over the age of 16. But if you're a child of the age of, if you're 15, you can consent for yourself. And I think, in fact, if you're 15 and have a child, you can consent for them, but don't quote me on that. Next is parent with right of access, brother or sister, any other relative, including in-laws, which I found out about a year ago. And then the office of the public guardian or trustee. I used to put down the PG&T, the office, quite a bit for their lack of, I guess, rapidity. However, over the last, I'd say 6 months to a year, they have been incredibly forthcoming and engaged in the process. If you call them first thing in the morning, around 8:30 or 9, when I think their office is open, you can usually have a decision by end of day. They've been very accommodating and have been very good. And in fact, some individuals from there have even come into hospital to assess the patient and provide consent in that form. So they have been have improved their process tremendously over the last year, as I said. So going back to the list here, so we've now hopefully identified the legally correct SDM. This now forms the crux of forming a treatment plan and finding out how to form a treatment plan. First and foremost, if you see number 3 there, the first question we will ask a substitute decision maker is there a living will? This is vitally important to document at the start of your encounter with families. I can't, again, there have been many times, unfortunately, where I've been involved in cases where there has been a living will, the living will has been fairly concise and applicable to the circumstances, and yet has been withheld from healthcare providers. This is not common, fortunately. However, in very confrontational cases, this has been withheld. You'll see sort of step B or 3B is, do you know your role? You're actually asking the substitute decision maker, and I think this is a vital encounter or opportunity to explain the principles of substitute decision making to those substitute decision makers. And after doing that, I think the key is finding out if they and their loved one have ever talked about this before. And I start with a very open-ended question and then focus in on specifics. So if it is someone with advanced metastatic cancer that there's no more treatment options available, I will specifically ask them about that. Have you ever talked about a situation where you are approaching the end of life, where there are no more treatment options available, how you foresaw, or have you talked about end-of-life care before? Most people, as you and I know, Quad, and from our studies, most people have not talked about this. And then I'll ask about specifics. Have you talked about CPR? Have you talked about the ICU? Do you know what the ICU is? Do you know what intubation is? And obviously, if they don't know what it is, explain it to them as best as possible. And the key here is documenting everything that you learn. And this is vital, again, to document right from the start, because things can change over time, especially, unfortunately, if the therapeutic relationship breaks down. And then if there is conflict between the physician or the treating team and the substitute decision maker, you can see over time that answers will change to this question. And it's very important to document it right from the start. So going forward, some of the things that's important to know about the role of the substitute decision maker is, just like a patient, a substitute decision maker must be competent, they must be willing, and they need to be available to make decisions. So getting to the competency part, you would assess their competency just as you would any patient. Again, the key here is providing them as much information as possible so they can make the best decision on behalf of their loved one. They have to be willing as well. So a partner, spouse or partner who was number 4 on the hierarchy could easily say, "Doc, I don't want this burden on me." And some people will use that term, or "I'm afraid of making this decision." They don't have to be a substitute decision maker. They can easily say, "I don't want to be." What they cannot do is then appoint someone in their stead. They can't say, "I want my daughter Jimmy," or excuse me, my son Jimmy to be the substitute decision maker, and I don't want my daughter Mary to be the substitute decision maker. They can't do that. It would just fall to the next individual in line. And they have to be available. Let's say they're on vacation and hours are different, or they're not answering their cell phone. You would then contact the next person in the hierarchy until that person is now available to consent to a treatment plan. And they must, as mentioned, be over the age of 16. Part B here is very important. Their role is to consent to a treatment plan proposed by the medical team. Their role is not to demand therapy. This is very, very important. If you propose treatment plan A and treatment plan B, the substitute decision maker has the right to consent to or refuse treatment plan A and consent to or refuse treatment plan B, but they can't refuse treatment plan A, can't refuse treatment plan B as well, and then come back and say, "I want treatment plan C." That is where they're overstepping their bounds as a substitute decision maker. And they must act on previously competent expressed wishes. And if there's no clear wishes, and this is what the consent and capacity board process will get into, is they must act based on values, beliefs, and best interests of the patient. And there is a best interest test, which I won't go into right now. So now getting to a treatment plan. So again, back to this. Your next step now is to propose a treatment plan. Oh, actually, before getting into that, it's very important, along with teasing out wishes applicable to the circumstance, it's just as important to find out what people value in their life. And I start off again with very broad questions, and I ask exactly that. What does your loved one value? Usually they'll say things like family, friends, being able to interact with people, being pain-free. But it's very important to tease that out. I'll actually ask further detailed questions about, do they value walking, talking, eating? focus in on activities of daily living and even intrinsic activities of daily living, and what they did for recreation when they were able to, and try to get to know that patient as best as possible, and as well about their beliefs. So not only what type of religion that someone practices, I don't think that's enough. It's also to find out how they were practicing the religion. So I asked family members, well, tell me what they would do. How would they do this? Trying to get to know that individual as best as possible. And after now that I have a general sense of wishes, values, and beliefs, I now propose my treatment plan. And this is very important as well. I don't want to come across as saying I'm acting as a dictator or I'm determining what is in the best interest of the patient. But in proposing a treatment plan, you need to remember that you are the qualified medical expert, and that based on not only someone's wishes, values, and beliefs, but their age, their comorbidities, what the acute process is, and the probability of reversal of that acute process, and more importantly, the ability to achieve physical and cognitive outcomes that are in keeping with someone's values. That's how I propose my treatment plan. And I always consider someone's wishes and beliefs and values, but that is not the overriding factor in what will formulate my treatment plan. At the end of the day, I think most physicians nowadays are getting better with using objective criteria to say, this is what we propose for your loved one, and this is what will be included in that treatment plan: IV fluids, antibiotics, investigations, but aggressive interventions like CPR, ICU, dialysis, whatever it may be, will not be included as part of that treatment plan. And I would say 95 to 98% of individuals or substitute decision makers that I propose those treatment plans to agree and consent to those treatment plans. For the relatively, I guess, lower frequency or the rare occasions where people will not consent to that treatment plan, that's where we move on to the consent and capacity board. So if I do propose a treatment plan, again, forgive me here because it's a little technically, we go to the consent and capacity board. And the consent and capacity board is basically there. It's an independent, neutral third body that is basically like a court. It's a quasi-judicial board. They will actually go pre-COVID. They will actually go to wherever the patient is. So if they're in hospital, they'll come to the hospital. If they're at a nursing home, they would go to the nursing home, and they will decide basically what is in the best interest of the patient. The patient automatically gets a lawyer assigned to them from the CCB. The substitute decision maker has the right to legal counsel, and if they can't afford one, you can actually provide information for legal aid, and they can go through legal aid to obtain legal advice. I recommend it to all substitute decision makers to seek legal counsel. The last thing I want to do is come across as a bully in these situations and not be forthcoming what the process entails. So it's important to, and your social worker can always help put them in touch, just to get a sense of what the consent and capacity board is like. It's a board that can be from 1 to 5 people. Generally, there's one person, the chair of the board, who will preside over the hearing. As mentioned, there'll be a lawyer for the patient, and there should be a lawyer there for the substitute decision maker. It's completely up to the substitute decision maker about whether or not they want legal advice. And unfortunately, in the past, my hearings have been delayed multiple times or adjourned because there's no legal representation for the substitute decision maker, or they've changed their mind, or they're not happy with the current legal representation that they have. And the process is pretty straightforward. You'd be asked to present your case, and you can call witnesses if you'd like. You provide, I guess, well-organized, basically evidence as well, and you'd be cross-examined on your evidence. Hearsay, unfounded or undocumented information is allowed, but obviously given less weight than what is actually there. So it brings back the importance of accurate documentation, and you and your witnesses will be cross-examined. This can take sometimes a while. I've had hearings last as long as 7 days, and cross-examinations last as long as, I think, 8 or 9 hours. So it can be quite, as mentioned earlier, onerous to the individual. Hearings can last all day. 9 to 4 is actually short. Usually they'll start earlier and finish a little bit later, trying to make the most of the day. Depends on the complexity of the case. Actually, you can be compensated for your time. I think I have the sheet in the next slide. And the nice thing about the CCB, one of the advantages of it, or positive things from the CCB, is you actually get a decision within 24 hours of the hearing ending. You can imagine going through the court system, usually takes months, if not a year or so, before you get a decision. So just a little bit more, this comes from Mark Handelman. The CCB has the authority to review the refusal of substitute decision makers. They will convene a hearing, usually within 7 days of the receipt of the application. So the way it works is you print off what's called a Form G application from the CCB website, you send it in, and within 7 days of receiving that application, there'll usually be a teleconference to try to sort out logistics about when the actual hearings will take place, dates, times, locations, to make sure all parties can attend. And that's what actually I find delays a lot of the hearings. And as mentioned, you get a decision within the day after the hearing. The important thing, I think, for all physicians to request as well is reasons for decision. I'm a huge advocate of this, even regardless of what the outcome is. I think it's very important for our learning, for physicians who take this task upon themselves in the future, to know and have as much information as possible. So as mentioned, this is a public hearing, and then after the fact, 4 days later, the chair of the board will basically report on what they found or what their finding was and the reasons for that, and can be quite laden with information. And the CCB has heard more end-of-life cases than all the Canadian courts combined. There are not, to my knowledge, I don't think there's any other similar process in any of the other provinces up until now. Now, you've heard a lot of positives about the CCB, but I'll get into it a little bit later on about some of the negatives of things. This is actually the reimbursement form. You can see there, it's pretty straightforward. So if you're a specialist, psychiatrist or medical specialist, greater than 3 hours, $1,100, and less than 3 hours, $554. Unfortunately, I'll advocate for my general practitioners that they're not paid as well as specialists, which again, I don't think that's fair, but I don't make the rules here. So here, issues with the CCB process. From time of application to decision is at least a month. That's the quickest I've ever been able to achieve a decision. Realistically speaking, you're looking at 3 to 4 months, which I know may seem a long time to a lot of physicians, but it's actually much more rapid than the court system. This part, I think, needs to change. The decision is solely based on law. It's solely based on the Healthcare Consent Act and Section 21. So has the substitute decision maker acted appropriately based on previously expressed wishes that are applicable to the circumstances, and actually, or values, beliefs, and best interests if there are no wishes, but it has actually very little regard for the medical standards of care or ethical principles, which I think needs to change tremendously. And you and I have written about in our previous papers as well. The hearings are long, prep time is even longer. Can this result in litigation? The answer is yes. I mean, honestly, taking on these challenging cases, I think one of the things you have to be comfortable with is knowing that someone can and probably will complain about you either to the CPSO or potentially bring up a legal suit against you. So it can result in litigation. I know that sounds intimidating, but I think it's the right thing to do. And I think basing your care on the fact that, well, I might get sued or I might get a complaint is not the way to be practicing medicine. And it can make the process never ending. And you and I focused in on this on the very first podcast when I was with you. You can see why physicians don't want to do this, because in some cases, you'll have a decision from the consent and capacity board, and then the substitute decision maker can obviously appeal. And the appeal process takes months of your time and can be challenging as well. Do you need legal representation for the CCB? Yes and no. I've done, I think, 8 cases now. In 3 of them, I haven't had any legal representation, and the rest I've sought legal representation. So it's completely up to you and what you're comfortable with. I would suggest for your first cases, and depending on the complexity of it, it's probably always wise to call the CMPA and ask for their help. I think we've gone through this. I'm just going to skip ahead here and just go to the case resolutions. And explain what we learned from these cases, and then we'll finish up there. I'll be about another 5 minutes, and then we can open it up for questions. So this 35-year-old woman, as you guys can read the stem there, what we learned from this case, there were two things. One, we were getting consent from the wrong SDM. We were getting consent from a sister, and in fact, there were children involved, and there were two children who were over the age of 16. And when speaking to those, the children, they had, one of them, in fact, had made it clear that they had had a conversation with their mom, and it was clear from that conversation 2 weeks before admission, actually, that her mom would not have wanted such aggressive care if there was no hope of recovery. And this did not go through the full CCB hearing. We had braked in the middle of it, and we managed to reach negotiation during the CCB hearing, which was endorsed by the board. Case two, unfortunately, this case went a full CCB hearing. There was no previously expressed wishes. And by the way, while I'm on the topic, you can look up these cases on CANLI, so CANLII. All the cases that have reasons for decision are available to the public and can be looked up. So this is why I'm speaking about them, is because they're actually public knowledge. I'm not using any names, as you can tell. So this case went to a full CCB hearing, and at the end of it, we found out basically that the patient's beliefs were the circle of life. And I honestly said, well, unfortunately, this individual is at the end of that circle. They are at the end of their life, and explained what further care would entail. And we received consent, or excuse me, the Consent and Capacity Board basically endorsed withdrawal of all therapy and initiation of palliative care. What we learned from this case is the importance of accurate documentation. As you remember, the patient's family multiple times to 3 separate physicians had said, our mom, in fact, they actually said, our mom would kill us if she knew that this was happening to her. And it was documented. It was documented on 3 separate occasions by 3 different physicians. And this was vital in this case. Again, I presented this at the CCB. Halfway through, after I presented this information, basically the lawyer for the SDMs asked for a recess. He came back and basically said, you know what, we are okay now with no escalation of care, and the next clinical worsening palliative care. This case, very difficult case, 86-year-old with advanced dementia, aspiration events, acute on chronic kidney disease. The important thing here is family is adamant based on his wishes he would want to live as long as possible, regardless of any suffering or indignity. The SDMs in this case, this went the full CCB hearing, and the CCB found that the SDMs are acting appropriately, and there was no consent to withdrawal or provide palliative care. I think the one thing, Quad, you know this case quite well, that we learned from this is the importance of formulating a treatment plan, and the importance of that substitute decision makers cannot demand therapy. And what we've learned from this, and what we've done as well for those of you that are listening, is we now at our city or divisional meetings, especially in ICU and sometimes on medicine, we'll actually have a portion of our meetings devoted to difficult cases where we discuss this as a group. And usually, not usually, in fact, every time we've had a difficult case, there's consensus about what the treatment plan should be and what we should do about this situation. And I think it's very important for physicians to, especially when you're in a group type of practice, to have the same message and communication with family members as much as possible. And that's what we learned from this. This provided a tremendous amount of distress, not only for the physicians, but the nursing staff, and as well, always looking out for family members as well. This was no easy process for the family involved. Finish up quickly here. These are non-CCB cases. Actually, Claude, you were involved in this. I think you remember this. In this situation, there was a partner making decisions. It was clear from us, based on some of the comments in the STEM, that the partner was not capable. If I remember correctly, you actually went through the CMPA, you formulated a letter, delivered that letter to the individual, deeming him incapable of medical decisions. And since he was no longer the substitute decision maker because he was deemed incapable, we went down the hierarchy to the next substitute decision maker, who happened to be a parent, and that substitute decision maker agreed with our palliative approach. Finishing up real quick here, 50-year-old female who can still communicate via eye blinking. The patient in this situation is still capable. They had a clear, according to the physicians involved, I was involved indirectly, clear understanding and appreciation of the situation, can still communicate a treatment decision. So there cannot be an SDM. The patient is capable. So unfortunately, the partner was removed from the room forcefully. The patient reiterated her wish to the treatment team, and palliative care was provided in that situation. The patient passed away peacefully. And I think just to tie up the last case, again, this brought in the issue of religion and the importance of, I think what we learned from this case as well, the importance of finding out how someone practices religion and their beliefs. This was crucial in our argument. In this situation, the Consent Capacity Board found that the SDMs were not acting in accordance with Section 21, and the SDMs were ordered to comply with palliative care. They appealed to the Superior Court. It was supposed to be a Superior Court hearing, but we managed through further sort of negotiation and parties managed to reach, I guess, an outcome that was suitable for both parties, so we could avoid the Superior Court. And I think that's it. Just to put in a plug for this, I think, I know the process is not perfect and it seems intimidating, but when there are difficult situations like this, I think we need to get better. And I would recommend to all physicians that if there are these difficult cases, to file an application to the Consent Capacity Board. Unfortunately, sometimes this is the only way to resolve a conflict between a treating team and substitute decision makers. I'm there to help. So if it's in Ottawa or Ontario, you can call me. I have no problem helping out with these cases. I'd have to commend a few of my colleagues recently who have done this. They know who they are. It takes a tremendous amount of work and effort to do this, and I'm very proud of both of them for doing it, and I've helped out, and hopefully it works out for both of them. And I don't think we can stop doing things like this. If we don't agree with the way the situation is, you need to write to your MPP or your Minister of Health and keep putting pressure on folks. I have, you know me, I've called the CPSO and emailed them multiple times to express my concern with their policies. And to be honest, the current regime at the CPSO has been pretty open and has welcomed my phone calls and given me time to express my concerns. So I have to give them credit. I think I will end it off there. It was pretty quick, but I want to give people time to answer questions. And more importantly, at 1 o'clock, I have pizza coming. So,
G, I want to thank you for laying it out like this. So one, people, you could write in your questions or comments, and I'll express them to Gianni. We've already had about a couple. So one thing I do want to say too to those listening, when we talked about you know, determining what their values are and what they were like as a person prior to getting ill. The other thing that's important to do is develop that rapport so that that family has that trust. So, you know, as we mentioned, 90+% of the time, people are going to go ahead with your treatment plan, but they're going to go with it when they have faith in you, when they have that trust, when you have that rapport. So that's another key step to establishing that rapport. The other thing I want to say too is just, and I don't know if I know we kind of emphasized creating a treatment plan, but just remember, if you don't feel something is in the patient's best interest or within like that, if the care would be futile or it's not going to get them better, do not offer it. Do you know what I mean?
Yeah, I think
you know what I mean? Like it ain't McDonald's, or, you know what I mean? Don't present it as as if it's a menu. Do you want X, Y, or Z? You know what I mean?
So the last thing, I mean, one last plug is I cringe when I hear the category discussion in Emerge or on the ward. If your heart stops, what do you want done? We need to, that is not the appropriate discussion to be having, or method of having that discussion. You need to really focus in on treatment plans and be honest with people why your treatment plan is including or excluding certain things. And I'm very adamant and direct with folks, especially in the setting of advanced dementia, for things like I find people have a lot of difficulty discussing feeding tubes. I will tell them this is consistent with end of life. A nasogastric tube or a PEG tube is not indicated. There are guidelines out there from reputable societies like the Canadian Geriatric Society. where I'll say it's not recommended. When I'm not doing it, it's not being offered.
Yeah, no, that's a good point. One of the questions that came up by Sheldon, I don't know if you're still there, you beautiful human being. I think he's only a few feet away from you, actually, is that we, in the ICU, we're not seeing that many long-term care patients despite the COVID outbreaks. Why do you think that is? Whether that's, people dealing with that in the community or in the merge in terms of appropriate goals of care? Like, what do you think is going on?
I think there's three factors. I think we always knew, unfortunately, that I think as physicians and healthcare workers that long-term care was underfunded. I don't think a lot of the public knew what truly long-term care was or the outcomes for individuals in long-term care were. So I think the public has become more knowledgeable recently, realizing that, hey, this is unfortunately going to end someone's life and that there is no cure for it. And they've seen that in the media or other resources. So I think the public has become more knowledgeable of it and has probably started saying or discussing with their loved ones that maybe we shouldn't do this for mom or dad, or had that discussion with mom or dad or their loved one saying, you know what, we should talk about end of life a bit more. Two, I think healthcare workers are getting better at this now, knowing that there is a tremendous pressure on the healthcare system. So we're getting better with discussing it. And I think three, long-term, like talking with Celeste the other day, is that I think the individuals at long-term care, the nurses, the physicians, I think they're discussing it a lot more with their patients as well. So, yeah.
Agreed. Okay, so we got a question from Omar. What's up, buddy? In light of oh my God, my kids. In light of offering treatment plans and excluding plans that you feel are futile, can you then explicitly not mention that you will not offer CPR, intubation, etc.? I'm muting.
So if I get that question right, in certain situations, depending on the complexity of the substitute decision maker or family, I'm always one for giving them as much information as possible. And I will almost always mention that the certain things will not be offered. They're not even on the table for the sake of clarity. If there is that, especially in that situation where there is confrontation, I want to make sure that the entire treatment plan has been properly explained, including what it will entail and what it will not include. If it's a different situation where there's more, I guess, agreement, if that's even a word, between the substitute decision maker and myself, in those situations, it's clear that they wouldn't even have entertained those aggressive things, so I don't even mention them. But if it is a very tense situation, I'll always mention it because I don't want this to come back at the consent capacity board or another legal setting and say, Dr. DeGio, you didn't properly provide informed consent. And I will specifically label and list everything that will be on or off for the treatment plan.
Okay. Next question from Cam. How you doing, big guy? A tough situation I've come across on race several times is when I see a patient who I don't feel would benefit from ICU care given their comorbidities, clinical presentation, etc. But other non-critical care physician teams have already offered these therapies. How do you approach these situations?
So in that situation, I equate it to, we are the experts. We're the experts in that field of medicine. It's not to put down my colleagues that are having these conversations, but more times than not, the conversations they have had have been done incorrectly. So for instance, I'll give you a case that I had the other day. Young female with metastatic breast cancer, innumerable mets to the brain. The physician had a discussion with the patient, and the documentation was, patient wants everything, therefore Cat 1. So in that situation, that is not informed consent. And if there was proper informed consent, it was not documented. So what I'll tell people most of the time is, I understand you had this conversation with this team. I respect them. They're very good, but they're not experts in critical care like I am or we are. And in that situation, I'll say, unfortunately, it's much like me consenting someone for chemotherapy for cancer. You can't do it. It's too complex. The same applies for critical care. And it's a fallacy of our system where I think non-intensivists these days are having discussions that I think, frankly, because of the technology, because of everything that goes into it, not that they shouldn't be having the discussions, but the discussions need to be more informed. So I will, more times than not, reverse or say, yes, that was offered by this physician, but the circumstances have either changed or the discussion wasn't had, frankly speaking, appropriately. And this is the reality of the situation.
Yeah, I can't emphasize enough too about, you know, the quote unquote non-expert opinion, or like a lot of people don't really know what an ICU admission entails. They really don't, actually. And they don't know how difficult it is. Like people just think, oh yeah, you're on a ventilator. No, like you are thirsty and can't drink. You can't express pain. You can't express your anxiety. You are drugged up. You could be having all these crazy dreams and not being able to articulate it. You're weak. You are suctioned repeatedly.
But even with that in mind, not to interrupt you, but you see that case I dealt with last week. That is an end of life case. There's no more treatment available. Like to say because the patient wanted it, I want Cat 1. That's great, but did you take the time to explain that there's innumerable? Like you should see the CT scan report. It's like, you know, one of those highlighted things. There's exclamation marks everywhere. That her brain, unfortunately, was full of tumor. Mm-hmm. And she arrested and herniated. That's the situation. So
yeah, no, that's fair. Like but I think it's just part of the puzzle too. Like just be like people, you know, bring up to people, oh, you want to come to ICU, no problem. Whereas, you know, are we really going to fix the underlying problem? Are we going to be able to achieve your goals? You know what I'm saying? And
well, the situations, and you know me, I'm outspoken. There's that picture of one of the orders that I wrote on one time where someone said, admit to ICU. And then there's my order underneath it about an hour later that says absolutely not, in exclamation mark, signed by myself. It's not going to happen sometimes. There's no way.
Yeah. I hear you, buddy. Is there any other questions out there? I think we dealt with most of the ones so far. And maybe just comment on how important it is more than ever, you think, during this during an pandemic, to be having these discussions.
Well, yeah, I mean, I think we will see things change tremendously after this on multiple different levels. I think the public will become more aware of things like frailty, expected outcomes for individuals. And there's no excuse not to be having these conversations now. People are home. People are not working. There's no better time to communicate with your loved ones than now. Ideally, I mean, unfortunately, it's not face-to-face, but on phone, FaceTime, whatever it may be, to really figure these things out. Especially COVID aside, we keep forgetting about COVID, but the impact of other diseases on individuals, like I think we've all forgotten about things like sepsis, influenza, cancers, all these things that can equally end your life and have some higher mortality rates than COVID. That we need to have these conversations, or at least start talking about them, because it helps us tremendously. And as mentioned in our podcast the other day about having that availability for either a second opinion or an outreach for someone who is an expert like us, or palliative care physicians, to have that ability to communicate with someone via a video like this to explain things to people. You know, you and I are completely on board with that.
Yeah, this is one of the things that I think could be a positive out of all this COVID BS, is that, you know, if there's an opportunity now that for us to connect virtually to people and say, hey, you know, I know you think this patient might be, or this patient thinks they might be a good ICU candidate, and to be able to have that conversation with a colleague on the phone and say why they may or may not be a good candidate, and add that perspective, that expert piece, I think would be a game changer, an absolute game changer.
And there's situations as well, to, I guess, advocate for myself as well, where there's situations where people have been DNR or Category 3, where I've looked at it and said, no, this is wrong. You are young, you are healthy. I don't think you understand what the ICU is, or what you can recover from this. You can have a very good life going forward.
Yeah, that's a good point.
So that is.
It's a good point to plug that too, because a lot of times people just think we're just all about, like, making everybody do not resuscitate. But I believe it or not, I did the same thing not that long ago with a gentleman that was in his elderly, but came in with a heart block, and didn't have a pacemaker in place. And I'm like, if your heart does stop, like, we could actually do something about it. And I actually told him, I reversed it, like, convinced him to reverse his status. And to be honest with you, he did arrest and we brought him back, and he got home. And it's just perspective. It's like, this is a good message too, is like not to have a cookie cutter approach to all this. Like, really look at who your patient is in front of you, and what the scenario is, and what the goals are. Because that's how you should frame things, right? It's not just like, oh, you're 93, or you're, for sure you should never be admitted to ICU. No, it depends. It always depends.
Hey, for the record as well, I want this recorded. I took a 102-year-old lady to the ICU once. Oh, I'm getting a call.
Yeah.
For a type B aortic dissection.
Of course.
And she did okay.
Absolutely. Well, listen, buddy, thanks for doing this.
My pizza guy.
Oh my God. Yeah. Feed the people, feed the frontline staff. We love it. And thanks for doing this. Thanks for listening, everybody.
Okay. Thanks, buddy.